So the presentation is on diabetic embryopathy in pregnancy. And case report, I'll hand over to Dr. Birkin.
Thank you. All right, so this is a 30-year-old patient, G1 P0. She originally presented to EA Conway at 28 weeks and 0 days. She was complaining of acid reflux, nausea, vomiting, some lower abdominal pain since the beginning of her pregnancy. For her past medical history and her review systems was pretty much non-contributory. She had history of GERD, she's obese, she's a B diabetic, diagnosed in 2005, supposed to be on meds but was not taking any. Asthma, no previous hospitalizations, and she uses an inhaler, last used about a month ago. No surgeries, she's a G1 P0. Her prenatal care this pregnancy had been at an outside hospital with an MFM, and she had been transferred to EA Conway because of a suspected fetal skeletal anomaly. GYN history, she had positive herpes, diagnosed in 2005 with her last outbreak earlier this pregnancy. No other STIs, no abnormal PAPs. She's taking prenatal vitamins and her albuterol inhaler, and like I said, she was prescribed glyburide but had not been taking it. Not allergic to anything, negative social history, and negative family history. For her vitals, blood pressure is 105/69, pulse 111, afebrile. She's obese at 242 pounds, at 5'2", that puts her BMI at around 44. Her physical exam was pretty much non-contributory.
Hold it down. Thank you.
She did have a trick on her wet prep, and fetal heart tones were noted to be in the 160s, fundal height 30 centimeters with a glucose of 105. 4 months previous, based off of her prenatal records that we had gotten from the outside hospital, when she was 9 weeks and 4 days, she had had a hemoglobin A1C drawn, which was 8.8, and also she was O-type blood, Rh negative, with a previous UTI this pregnancy. So she had an ultrasound at EA Conway that measured her at 843 grams, which was less than the 5th percentile, and notably the femur length was measuring 22 weeks and 6 days, less than the 5th percentile, so it was lagging behind quite a bit. Breech, again, 160 heart tones, and AFI was normal. So she had her routine lab work done, again, Rh negative, H&H, as you can see. Pretty much the only things of note were the trichomonas on her pap, and then she had a Klebsiella pneumonia sensitive to macrobid urine culture. So she was given Rogam at this first visit. She was given Flagyl, a prescription for macrobid, Zofran, Protonics, and she was sent to see diabetic education, put on diabetic diet, given glucose supplies, and then she declined the Tdap and the flu vaccine at this time. So for her follow-up clinic visits, 31 weeks and 0 days, she had completed her course of macrobid. She did not bring her dextrose log to that visit, but she stated that they were between 90 and 120. She was taking her glyburide, and she was given Rosefin 1 gram for the persistent UTI. At 32 weeks and 2 days, she had a level 2 ultrasound here at LSU, which showed estimated fetal weight of 1829 grams with 32nd percentile. Her femur length was again small, less than at 2.3 percentile, and this was in comparison to her previous ultrasound. The femur had totally grown just 9 millimeters over the course of 2 months. The humerus was also less than 5th percentile, so was the tib, fib, and the radius and the ulna. So she began twice weekly fetal testing, had a NICU consult, and the recommendation was placed to consider an amniocentesis at 38 weeks and an induction. So you can see she had this severe shortening of her femur at this point, and it was thought to be possible skeletal dysplasia versus the diabetic embryopathy at this point.
So this patient, this could be diabetic embryopathy, but it well could be a skeletal dysplasia. The other important part of her history is when she came to see me is that the father was advanced paternal age. He was, I believe, 68, maybe 58. Anyway, he was. So with advanced paternal age, there is increased risk of skeletal dysplasia, particularly achondroplasia. But anyway, so because the femurs were mainly involved, the tib and fib and radius ulnar and humerus were just mildly shortened. They weren't that bad. I was leaning more toward the diabetic cause. So we want to look at many different things on this fetus because with diabetic embryopathy, you can basically have about everything messed up. And we're going to go through that in our presentation. So in this image, we're looking at the spine. The head's here. Cervical spine, we don't have a real good picture, but we did look at that. Thoracic spine, lower thoracic spine, lumbar spine. And I really couldn't see the sacrum real well. This lady is rather large, so I can't say the sacrum is normal or abnormal because we didn't have a real good image of it. So sacral agenesis would be part of diabetic embryopathy. This lady actually is in fact supposed to be seeing me at this afternoon, so we'll try to take a good look at that. They can have CNS abnormalities, including holoprosencephaly. That did look normal. Probably the most common thing is cardiac abnormalities. And again, she was a challenge due to her weight. So we had this 4-chamber view, which was not fabulous. Left ventricle, right ventricle, left atrium, right atrium. Can't even really see the descending aorta very well on that. This is supposed to be the pulmonary outflow. You'll just have to take my word on that one. And this is supposed to be the aortic outflow. And again, they appear to be normal, but not fabulous images. Then we have all these bone lengths, and we can see this is the femur, and it is 22 week size, and this lady is at 32 weeks. I think that's 32, it's kind of blurry there. The tibia was not that bad, 29.2. The humerus, 29.2. The radius, 26.4. So those were also shortened, but more of a mild type than the femur. The femur had severe shortening. And so this kind of tells you the story a little better. We can see that the head circumference is a little large. The BPD is pretty normal. And so this might actually lead you to think about achondroplasia because they do tend to have large heads, frontal bossing. The abdomen is normal. Then we can see this femur is less than 2.3%. So on this bar graph, it's just way, way over here. This is tibia. It's not quite so bad. Fibula, which is right at 11%. And then our humerus, radius, and ulnar are shortened. But again, if you look at the weeks EGA compared to the 32 weeks, which she is by the early ultrasound, she had her first provider, then they're more mild than severe compared to the femur. And so if we look at the graphs, so we can see here's humerus, radius, so they're right around the 2nd percentile. Femur, this is the measurement I did. This is a measurement that was done at Conway subsequent to the time I saw her. So I looked at the image, it looked pretty good, so maybe it's grown, and that would be good. And here's the tibia here on the graph. Then if we look at graphs of head circumference, we see that's fairly normal. Abdominal circumference also fairly normal, and biparietal diameter normal as well. Now one thing I wanted to kind of talk to y'all a little bit is about doing weight calculations. When you're in Viewpoint or you're on your ultrasound machine, you can choose from a variety of formulas. And so sometimes you don't want to choose the standard formula. So the standard formula that we generally use is the Hadlock formula. Dr. Hadlock's a radiologist who was at UT Houston, and he first published these, and this was a large indigent, mainly African American population, so it would be very applicable to our population as well. And he used biparietal diameter, head circumference, abdominal circumference, and femur length, okay? But what's the problem with using that for our weight calculation? Well, the femur is abnormal. So when you have a fetus that has long bones that are abnormal, if you start using a formula that has long bone lengths to calculate weight, then you're going to get a weight that is likely to be incorrect. You can choose formulas that don't have long bones. There's a Hadlock formula and there's also a Shepard formula, and they both use BPD and abdominal circumference. So if you can see, if we use the one with the femur, it looks like this baby's growth restricted on weight, but if we use the one that doesn't include the femur, then we know that its weight's likely normal. It just has the short, long bones. Any questions about ultrasound? Okay.
Okay, so pregestational diabetes affects about 1% of all pregnancies, and there's 8 million women in the United States that have pre-existing diabetes who have a potential to be affected by this. Most of the risks are related to the glycemic control, how well their blood sugars are managed, as well as the pre-existing vascular complications if they've had heart attack, stroke, evidence of vascular disease. There's a couple of increased risks during pregnancy. They have a higher rate of miscarriage, higher rate of preterm delivery. That's both spontaneous due to preterm labor and iatrogenic because of complications of diabetes. There's obviously this presentation is about the embryopathy or birth defects. You can also get more larger babies with macrosomia. There's an increased risk of fetal demise related to known complications like preeclampsia, as well as unexplained fetal demises where nothing is found to be the inciting factor. And also an increased risk of polyhydramnios, just greater amount of fluid. For the neonate, they have a higher rate of respiratory distress syndrome. The hyperinsulinemia appears to limit the lung maturation, and so babies of the same gestational age, diabetic versus non-diabetic, may have different rates of maturity. Early babies that are diabetic may have a higher rate of having respiratory distress syndrome because they don't get that surfactant and going and need extra help, or like a baby that was born even earlier. Right after delivery, the baby is cut off from the mom's high blood sugar, and they've been spending their time in the womb making their own insulin to respond to that maternal blood sugar. And so when they're born, they usually keep up this neonatal insulin rate, and in the absence of the mom's wash of blood sugar coming over them, they get hypoglycemic, so they have to be watched extra careful for that. Goes along with this, they get hypocalcemia as well. They're at a higher risk of some jaundice, polycythemia. They have a higher rate of hypertrophic cardiomyopathy. And there's a few studies that show there may be long-term effects on neurocognitive outcome, that these babies don't do as well on IQ tests and things like that. For the mom, they have a 0.5% maternal mortality, which is pretty high compared to the rest of the nation. That's mainly due to ketoacidosis. Moms can have diabetic coma easier while they're pregnant than when non-pregnant. And also hypoglycemia episodes where they maybe just getting control of their blood sugars and then have a hypoglycemic episode. Also complications related to hypertension, infections after a delivery or after a C-section, and if ischemic heart disease is present under the conditions of diabetes and pregnancy, that can be pretty high risk. There's a 3 to 4 time increase in the rate of preeclampsia in diabetic mothers, and that's increased to 12 times if there's pre-existing hypertension on top of that. Diabetic nephropathy, they used to think would be worsened by pregnancy, However, a lot of studies have shown that people don't really worsen during pregnancy. They just kind of have the normal course that they would have had without the pregnancy, unless maybe there's a few people, kind of case reports of people hitting renal failure during pregnancy. It's unclear if under conditions of severe disease, if pregnancy makes the renal disease worse, or if they were already so close to hitting renal disease, they just happened to hit it during pregnancy. Diabetic retinopathy is worsened by pregnancy. Part of that is the sudden control with blood sugars during pregnancy is thought to worsen the retinopathy. And so patients need to be counseled that if they have some retinopathy going on, it may get worse during pregnancy. There's also diabetic neuropathy. This, again, doesn't get worse with pregnancy, but it can be a pretty big morbid factor with pregnancy, especially gastropathy. Since pregnancy makes you nauseated and vomit and get hyperemesis anyway, having gastropathy on top of that can make for worse outcomes. Hyperemesis gravidarum isn't associated with worse prenatal outcomes, but having diabetic gastropathy is associated with worse perinatal outcomes. So, ketoacidosis affects 1 to 10% of diabetic pregnancies, and it can happen at a much lower glucose level. The mean for pregnant women in one study was 293 compared to 495 of non-pregnant people. Diabetic women also are at a high risk of yeast infections, urinary, upper respiratory tract, cold, flu, postpartum infections such as endometritis and pelvic sepsis. They have a higher rate of asymptomatic bacteriuria and more wound complications after C-sections. So these are the birth defects most associated with diabetes. Neural tube defects are pretty well associated with them. The other thing is congenital heart defects. Neural tube defects and congenital heart defects are the most common birth defects associated with diabetes partly because they're the most common birth defects in general. Some things that are even stronger related to diabetes are the Sirenomelia or Caudal regression sequence. Although those birth defects are rare overall, including in diabetics. This is an example of a baby with caudal regression syndrome. They don't have an appropriately formed sacrum. This is a baby with Sirenomelia. It's one of the 3 surviving babies that have ever survived long-term with Sirenomelia. Spina Bifida is obviously a defect in the nervous system. Anodia is associated with diabetes. It's malformation of the ear. And omphalocele is associated with diabetes. This is a study that looked at the relative risks of having any major fetal malformations and having diabetes, and they found obviously having pregestational diabetes had an odds ratio of 4.4 for having a congenital defect. They also found that class A2 gestational diabetics, women who needed medication control of their diabetes and had a fasting hyperglycemia earlier in pregnancy, had a slightly increased risk. That may represent people with undiagnosed type 2 diabetes going into pregnancy. So a little bit of history of diabetes in pregnancy. Before the 1920s, before insulin, most type 1 diabetics didn't really make it to childbearing potential, and if they did, there was a very high mortality rate. But after insulin was developed, people could kind of shift their focus from keeping the moms alive to trying to make a better neonatal outcome for them. In the 60s and 70s, surfactant was developed, and that was finally a treatment for the increased respiratory distress syndrome that diabetic babies have with their less mature lungs. And it also helps since diabetic babies tend to be born a little earlier than average. So the big study that we get White's classification from is this one, Pregnancy Complicating Diabetes, published in 1949. Priscilla White talks about how she managed diabetic pregnancies. She says that the goal was to prevent fetal deaths, premature delivery, and preeclampsia. And they mainly did this by controlling diabetes. Some things we don't do anymore is substitutional hormonal therapy. They were giving DES to patients, which we definitely don't do anymore. They also tried to correct the edema and hydramnios by giving people ammonium chloride for diuresis. So we don't do that anymore either. And they tried to manage premature delivery and special care of the infant. Back then, they didn't have surfactant yet, so their special care of the infant involved trying to keep the infant upright so that fluid on the lungs could drain downwards instead of upwards, and they really didn't have a lot of treatments for the infants. But
Remember that, Dr. Clement?
Yep. She was before her time, Priscilla White. You know, the classification is based on three things: duration of diabetes, age of onset of juvenile diabetes, and whether you're insulin dependent or not.
Mhm.
And as you said, it was described in the 40s, late 40s, but it's still true today. We use those three criteria to prognosticate what's going to happen to the mother and the baby. Sorry, didn't mean to interrupt you.
it's okay. So the original classes were made kind of looking at the outcomes of pregnancies, fetal survival, neonatal survival, and these were the original classes. Like you said, they're related to the duration of diabetes. Back then, they didn't focus as much on type 1 versus type 2 diabetes. So it was more important the duration that diabetes had been there. More recently, these are the current classes of White's classification that we use. It includes gestational diabetes, which was added on later, and it looks at diabetic nephropathy and retinopathy, the presence of kidney transplants, which probably wasn't very available in 1949, and ischemic heart disease. People have suggested changing the classification system now that we put a lot of focus on type 1 versus type 2 diabetes, and just having gestational type 1 with and without vascular complications, type 2 with and without vascular complications, and diabetes caused by other problems such as pancreatic disease, drug-induced, something like that. So the etiology of diabetic embryopathy, they have a lot of, they have some pretty good mouse models. Apparently, mouse embryos act similar to human embryos under conditions of hyperglycemia. So they looked at why exactly this happens. Part of it could be just the hyperglycemia itself, having a high blood sugar. Having a high sugar in the area changes the gene expression and changes the embryology. Having hypoglycemia in the mouse models has also shown effect on creating birth defects. In human studies, whenever they've tried to give people close sugar control, they have not seen an increase in human birth defects when women have multiple episodes of hypoglycemia. And so it's still considered safe to get close sugar control of women, but it is something you still want to avoid because in the mouse models they did see birth defects in mice embryos that underwent hypoglycemia. When they gave mouse embryos just sugar, they had a lower rate of birth defects than when they gave mouse embryos the whole serum of a hyperglycemic mother mouse. And so they think that other factors in the hyperglycemic state also cause birth defects, such as the ketosis, reactive oxygen species, and there may be a genetic factor. Some people with certain genes may be more likely to get birth defects under the conditions of hyperglycemia than other people. There have been studies that show there's a greater, if you look at this, the M stand for associated with multiple birth defects, including that one birth defect, and the S's stand for as a single birth defect. Some studies have shown that having multiple birth defects is more related to having diabetes than having just that one single birth defect by itself. So there may be a genetic component to reacting to the hyperglycemia. So a lot of people have tried to find ways to prevent birth defects in the conditions of pregestational diabetes. The number one thing people have looked at is glycemic control. You can't exactly take one group and give them good glycemic control and take another group and not give them good glycemic control. But what people have looked at is people who came to their clinic and got preconception care versus people who came to their clinic after conception and later in pregnancy and started getting care at that time. And so then you have two groups, one who probably had better sugar control than the other. And so these are their two groups. They had most of their people show up between 6 to 8 weeks, but some were even as late as 32 weeks. So they had 12 major anomalies in the post-conception group, or 10% of their group, and only one anomaly in the preconception group, and this was statistically significant. Looking at the groups that they had, if you had a greater than 10.6, this is the hemoglobin A1C, the top row, greater than 10.6 gave you a 25% chance of having a birth defect, so that's pretty high. Other studies looked at retrospective control of diabetes, and they looked for markers of pre-pregnancy care, like having a good A1C on their first prenatal visit and any record of them getting preconception counseling, things like that. And so what they found was having a planned pregnancy had an odds ratio of 0.4 of having a birth, this is really just bad outcomes. They included miscarriages, perinatal death, things like not just congenital anomalies, but they found much better outcomes with planned pregnancies, taking folate, and discontinuing contraception only after achieving an optimal hemoglobin A1C. One thing that might be important in diabetics is folic acid supplementation. One of the most common birth defects associated with diabetes is anencephaly, and so taking folic acid might be extra important for diabetics. These people looked at diabetes and taking folic acid. They used the National Birth Defect Prevention Study, which was a big chart review, and they looked at odds ratio for pre-existing diabetes and the use of folic acid preconceptually. And they found a pretty big association. Having any congenital heart defect, the odds ratio increases to 13 if you have pre-existing diabetes and no use of vitamins, versus 1.13. Actually, that's not even significant. So, and then the diabetics who did use vitamins just had an odds ratio of 5.5. So you can see that would help a lot. And then for any birth defect, diabetics who did not use folic acid had an odds ratio of 9.7 versus an odds ratio for 3.3 for taking folic acid supplementation. This is anencephaly and neural tube defects are associated with this. Sacral agenesis had a big, oh, actually any neural tube defect, but they didn't find an association with spina bifida in this study.
So that's closed spina bifida.
Yes.
Okay.
And then sacral agenesis, they found a benefit in taking folic acid versus not. Another factor is obesity, which has actually been identified as a risk factor separate from diabetes. So these people looked at diabetes and the rate of birth defects. They also use it's the same people actually with a different study. They use the National Birth Defects Prevention Study. And what they found was an increase in birth defects in the obese category. It's associated with diabetes. So you can see all the red boxes are significant, and even with pregestational diabetes, there's definitely a big association between that and birth defects. But in the gestational category, obesity with just gestational diabetes showed an increase in birth defects. So that may also represent kind of insulin resistance or kind of pre-diabetes or undiagnosed diabetes going into a pregnancy. Okay, so the goals for preconception care, it's good to have a planned pregnancy, to have a hemoglobin A1C that's optimized before conception, since organogenesis happens in the first 10 weeks of pregnancy. You kind of need to have that good hemoglobin A1C before conception happens. But half of pregnancies in America are unplanned, so about 30% of diabetic patients seek preconception counseling, and so that's a lot of people who don't even really see an OB before they conceive. Some people have suggested primary care providers step in and kind of do some preconception counseling just at regular visits of any women who are childbearing age. The goal for glucose control before conception is a hemoglobin A1C of less than 7. That makes your risk of birth defects about equal to the general population. Everyone going into a pregnancy, they want to take folic acid, and especially important for diabetics. It's good to have retinopathy or nephropathy evaluated and treated before pregnancy. There's not necessarily a contraindication to do a laser ablation of diabetic retinopathy in the middle of pregnancy, but just to avoid the effects of anesthetic drugs and things like that on the pregnancy. You can have it done before pregnancy and then not have to worry about too much worsening when you get that first good glucose control at the beginning of pregnancy. It's good to have a 24-hour urine collection for protein and creatinine clearance. If there's any evidence of vascular complications, get an EKG and echo. And type 1 diabetics, 40% of them have some evidence of thyroid dysfunction, so you can have that testing done preconceptionally and then get it under control before conception. So in the first trimester, when people come in, it's good to get good glucose control. You can either do, for type 1 diabetics especially, they always do insulin treatment. There's an insulin pump you can use. That's good if your patient is motivated and very compliant. It requires a lot of education to use. Otherwise, you can use the multiple daily injections, which we're used to giving. Teaching people to self-monitor their glucose, take their glucose 4 times a day, fasting in 2 hours after meals or 1 hour after meals. Good to get people on a good diet exercise regimen that helps with glucose control, and give people hypoglycemia precautions. In the first trimester, some of the insulin requirements may actually decrease for some people, so they're at a higher risk for hypoglycemia, both if they're getting their sugar under control for the first time and just because of their general insulin requirements decreasing. And you can some people suggest hospitalizing if the sugar is very uncontrolled going into the first trimester. In the second trimester, you have a more stable period. The insulin requirement starts to increase gradually, and it's a good time to start testing for fetal anomalies with a targeted ultrasound and NSAFP to look for neural tube defects. And in the third trimester, focus kind of shifts towards trying to prevent perinatal mortality. Giving people kit counts, NSTs, BPPs, can assess for if there's any kind of long-term fetal compromise going on. It's suggested that this starts at about 32 to 34 weeks, unless there's some other pregnancy complication that indicates it to be started earlier. And diabetics have shown an increased risk of stillbirth 1 week after a reactive NST, so they may need it more frequently, twice weekly, which is usually what we do here. You don't have to do a C-section just because somebody is diabetic, but they are at a higher risk of having a C-section for various complications. And it may be considered if the fetal weight is greater than 4,500 grams. That puts diabetic women at a higher risk of shoulder dystocia. You can keep people pregnant all the way up until their due date as long as the fetal testing is reassuring. And during labor, you want the glucose level to be less than 110 because this is the appropriate amount of glucose for the baby to be exposed to and will get their insulin level appropriate for delivery.
So just to update on the patient since the beginning of the visit at EA Conway. The patient presented at 32 weeks and 2 days with Dr. Urson for a genetics appointment. Her cell-free DNA was 46XX, and then Dr. Urson also addressed the 62-year-old male partner being advanced paternal age.
Karen, you can't tell how many chromosomes with cell-free DNA. You're just looking at 5 things.
Oh.
13, 18, 21, X and Y. So when you say cell-free DNA, it's either low risk or it's abnormal.
Okay.
So it's low risk.
So low risk.
Thank you.
And then at 33 weeks and 3 days, the patient came in complaining of pelvic pain and spotting. Cervical length was found to be 1.8 at that point. She was sent to the labor unit for steroids and prolonged monitoring. FFN was negative. She received ROGAM, and her repeat cervical length was 2.2. She was sent home. She represented at 34 weeks and 3 days for a routine visit. Dextrose log was normal. She again had a Klebsiella pneumonia, urinary tract infection. She was GBS negative. She was given prophylactic macrobid. And then her most recent ultrasound at 34 weeks and 3 days had estimated fetal weight of 1,868 grams, which is less than 5th percentile. The abdominal circumference was 23%. The femur length was still less than 5th percentile.
Okay, and that's about it. I thought it was interesting that this patient had a bunch of kind of recurrent UTIs, asymptomatic bacteria, since that's a complication of diabetes. If anybody has any questions.
You did a great job giving an overview and 2 editorial comments. Are you familiar with, have you seen the movie, why am I getting a blocker on?
Rambo?
Magnolia?
Yes, I have.
That's a true story.
Mm-hmm.
The mom was here, our head nurse in the pediatric ward, and the dad was the resident.
Rambo had diabetes too.
The point I'm making there, I'm not sure what you're saying, because during pregnancy, my understanding was that renal functions definitely worsen. Same way for the ROP, diabetic retinopathy. During poorly controlled diabetic or with ketoacidosis, the chances of both renal and retinal getting worse.
I think what the more recent is it doesn't really appear to worsen the renal status, but people who are on that borderline of renal failure.
Right, the creatinine. There are numbers in the creatinine ratios.
But in general, whatever their baseline generally doesn't change.
Yeah.
With pregnancy. So
the other comment I had was It's a misnomer to call it caudal regression sequencer syndrome because it has never developed, so it cannot regress. So it's just semantics there. But,
Okay.
But all of us who are old have seen patients with Sirenomelia, and the severe complications are horrendous. So it's so crucial to control the ketoacidosis and the A1C. We keep it below 7, as you said, or 7.5, as you know, in pregnancy it's raised. The complications are abolished, at least from the wonderful studies from England and here.
That was a very nice presentation. On a practical point, this lady's on Monroe,
Yes, sir.
Yes.
and now that she's pretty close to term, is the plan is to electively deliver her at Monroe?
No, we're going to amnio her, and if she has a mature LS ratio, we're going to induce her here. Unless she just goes into labor in Monroe, then we'll just have to deal with that at that time.
Pretty severe growth retardation though.
But it's not growth restricted. That weight she's getting, that's because they used the wrong formula.
Oh.
The weight's fine.
In that case, is there any harm to let her drag on a little longer than you?
Is what?
You're going to amnio her, what, 37 weeks?
Maybe 38. I mean, because she's diabetic. I want a positive result. I want a negative result.
President just said, the kids hang in there.
Well, she's got a short cervix. I mean, it's just a little tightrope we have to walk every day, and hopefully we don't fall off.
If she comes in, from...
I mean, if I amnio her at 37 weeks, she's more likely to be immature, given she's diabetic.
Yeah.
So I would try to wait till 38, amnio her, and I'd just keep her here and wait on her result. And if it's positive, then we'll induce her.
It's certainly not an urgent thing, but it's certainly not reasonable for us to say hello to this.
I think she's going actually this afternoon after I see her. So just with her being in Monroe, we have to, it's a little harder on that coordination.
Didn't you say it was 1 kilo at 36 weeks or something?
That's
The
not,
latest one?
that's not correct.
That's one, okay. That's why I was saying it's a growth rate.
That's not correct.
Good.